Thank you for the introduction. And actually, we are giving almost the same concept of Yttrium 90 for these 3 talks, actually. But yes, I will share some of my concepts and maybe almost the same. We are moving, maybe downstaging concept because in Taiwan, most of the time we do for advanced HCC before, but now we are moving to another era. So for a good Yttrium 90 treatment, I think optimal patients, suitable tumor size, and adequate dose when precision makes intention, cure becomes possible. So nowadays, I want to update it, the ESO guideline 2025 because now I have already showed this this picture because now when patient comes to us, no matter what stage, maybe A, B, C, D of the BCLC staging, but all we want to think is that are we going to cure the tumor or it's going to be the disease control. So if Yttrium 90 can play a role for tumor ablation. So for this we call it for curative intent. So we can do for the ablated intent. And also, Yttrium 90 can also do for disease control, for palliative intent. So Yttrium 90 in ESO guidelines that it has played 3 key roles for ablation, conversion to curative therapy, and disease control. So it is quite important that Yttrium 90 can have both curative intent and palliative intent. So for curative intent, the first role of Yttrium 90, we call it the radiation segmentectomy. For this kind of purpose, we do it for curative option for selective HCC patients, and for this kind of situation, we delivers the ablative dose. And to reduce the side effect and alternative to percutaneous, it is also an alternative to percutaneous ablation. So this is one of my case for radiation segmentectomy because in Taiwan we don't have many chances to do the radiation segmentectomy. So this 70-year-old male with HCC, actually it's already stage B, but the tumor is still small with taste for 4 times. The patient refused to have taste anymore, so we do it for Yttrium 90. So the patient had 4.4 centimeter located in segment 4. Actually, it's a good case because we only have to super select the segment 4 and then we give 1 gigabit of Yttrium 90. And the upper part is the MRI images. You can see that the hypervascular tumor. Then after the treatment, you can see the tumor got necrotic well. So after the follow-up, it is a complete response case. Then the Yttrium 90 of the second role of Yttrium 90 is to curative conversion. It means that sometimes we do Yttrium 90 for intermediate HCC for potential cure after Yttrium 90 treatments. And for this kind of situation, we can do subselective or super-selective radioembolization. And the target absorbed dose at least 200 to 400 gray. And also I want to share this, that updated in Taiwan Liver Cancer Society, we have our stage B HCC recommendation treatments. Yes, we already put Yttrium 90 into stage B recommendation treatments. So this paper has already shown, already shared by Dr. Kim, but for the legacy study is encouraging for Yttrium 90 because we can have a radio segmentectomy for this high dose of the for the Yttrium 90 treatments. For this study overview, I will go through very quickly. So it's for solitary unresectable tumor smaller than 8 centimeters, and the dosimetry should be up to 410 gray for treated volume. So the clinical significance is that the efficacy of objective response rate is around 88.3%, and the 3-year objective response overall survival is almost 87%. So the key insight of this study is to delivering high dose, more than 400 gray, to achieve a complete pathological necrosis. We call it an ablative dose threshold. But actually, for the Western HCC, most of the cases are very small tumor size. So you can see that median tumor size was only 2.7 centimeters, and only 9 tumors are more than 5 centimeters. Then this is the, most important part of my sharing, where I'm going to share the doorway Yttrium-90 study because it's just launched recently. So for doorway Yttrium-90 study, the study designs is prospective, and for multi-center for about 14 sites, and evaluating by Yttrium-90 raceme microsphere. And the innovation is that this is the first study using the personalized partition dosimetry ranging from 150 to 400 gray. And the treatment approach is to use partition model, but it can be retreated if the mean tumor dose is less than 100 gray. So the clinical meaning is that it can optimize the Yttrium-90 dosing, improves tumor control, downstaging potential, and safety. So let's see the doorway study co-primary endpoints achieved. For best overall response reaches the 98.5%, and the best complete response rate is about 92%. And 100 local tumor control rate. The median duration response is 300.5 days. So actually, it's quite exciting for this kind of data. So the total absorbed dose is up to 435 gray. They use the partition model, and the median TAD is 513 gray. The medium size is 2.7 centimeters still, but ranges from 0.3 to 8 centimeters. So let's compare both of these studies. The doorway study is prospective, but legacy is retrospective. But doorway study can reach up to objective response rates almost 99%. So it's quite promising to do this kind of treatment. Then move on to the summary of clinical outcomes from Yttrium-90 treatments of HCC. Actually, we can see that as higher dose as the Yttrium-90, we can get a better outcome. So dose does matter. And also for raceme, we know that the good coverage that ensures the therapeutic effects predictable. So coverage does matter. A 66-year-old male with HCC up to 15 centimeters, it's quite a large HCC. But we still try to conversion to operation. So we do the Yttrium-90 treatments. Then after the Yttrium-90 treatments, we also performed one time of depth test. And we saw the tumor got necrosis and decreased the vascularity. So the surgeon got operated the tumor. Move on to disease control because most of our HCC are still stage C or stage B. So for disease control nowadays, we want to combine with systemic therapy. So Yttrium-90 will show the immune activation for this kind of combined treatment. But higher dose, the higher tumor dose will have better objective overall survival and disease control. And SARA trial shows dose-response correlations, not treatment type. So when precise dosimetry is achieved, actually outcomes will improve. We know that most of the HCC, the hepatomas, are still cold tumor. They are not really good outcomes for only monotherapy for immune therapy. So when we combined with yttrium-90 with immunotherapy, it's going to be better outcome because of the activation of the immunogenicity. So these are the summary of key studies that yttrium-90 combined with immunotherapy. So you can see that there are several studies, that including combined with atazobeth or durva. So, but you can see that all the combined studies shows promising better objective response rate and overall survival. A 64-year-old male with HCC around up to 8 centimeter. Actually, it's not a good location either. Then we performed the yttrium-90 up to 600 of gray, and we superselect middle hepatic artery, right hepatic artery, and left hepatic artery. And also combined with immunotherapy. So after the combination treatments, the tumor got necrosis and the segment got shrinkage. So the patient get operation. And the necrotic mass is around 6 centimeter, and the viable tumor is only 1 centimeter. So yttrium-90 plays 3 key roles: ablation, conversion, and disease control. The doorway study, which represented a milestone in personalized radioembolization using partition dosimetry, 150 to 400 gray, and it will get a good response, objective response rates up to almost 99%. And also, it's a favorable safety profile and with good dose coverage for this across the treated lesions. Once again, for a good yttrium-90 outcome, optimal patient, suitable tumor size, and adequate dose. Thank you.